Hi everyone, welcome back to Medical Cebu. In this video, we'll be covering about the topic that is subdural hematoma. Subdural hematoma is a neurosurgical condition. The term subdural hematoma basically refers that hematoma in the basic term is the collection of blood, and so blood collection is referred to as hematoma. It can occur anywhere in our body. Uh, when this hematoma occurs subdurally, which means sub, um, which we say as submarine, below the water, dural, that is dura mater, that is the layer of the brain. So we have few layers of our brain, starting with our skull. We have then the dura mater, the arachnoid matter, and the pia matter. So for the dura mater, we have two layers, that is the periosteal and the meningeal layer. So here we can also see that we have the dura mater as the outermost layer. Below it we have the presence of the arachnoid, and inside we have the presence of the pia mater. So in between the dura and the arachnoid is the space where we can get the subdural hematoma. It is in the subdural cavity, we can say, where we have this presence of bridging veins. These bridging veins are usually prone to rupture due to any traumatic or non-traumatic causes, which we will see in a minute, the etiologies. So this was the basic definition of the skull layers, brain layers, along with what subdural hematoma refers to. So we mentioned it as the tearing of the bridging veins and the blood getting collected between the brain and the skull. The veins are torn, which leads to the leaked blood and increased ICP. So this increased ICP, the intracranial pressure applies on the brain, and it usually leads to the high amount of pressure leads to various neurological disturbances, which we will discuss. So the common etiological factors for a subdural hematoma will be any traumatic head injury, like traumatic brain injury in a motor vehicle collision, and the most common population which are prone are the elderly, due to the fact that with age the brain size shrinks, and this shrinking in size of the brain leads to the stretching of the veins inside, especially those bridging veins which we saw earlier. These are more prone to stretch, and the stretching will more prone to bleeding. Some other causes of cerebral atrophy are alcohol abuse, chronic alcohol abuse, neurodegenerative diseases are also the factors. If the patient is on anticoagulant or any blood thinner or any antiplatelet agent, all the class of medications are at risk of increasing the subdural hematoma. Falls would be another common factor. Sport injuries. So we have people in sports playing football. Although they wear helmet, the impact of the trauma is severe enough to cause the sport injuries, leading into a subdural hematoma. Subdural hematoma would usually present with the uh, sudden onset of headache. The headache may be mild. With time, you may feel symptoms of tiredness, confusion, and memory problem if it tends to present as a chronic subdural hematoma. In acute cases, we usually have the headache as the most common symptom, along with other symptoms which we will see. In the pediatric population, in the traumatic cases, we can have shaken baby syndrome as a cause. Shaken baby syndrome, in which when the baby is forcefully shaked, the acceleration and deceleration movement of the head of the baby causes the rupture of those cortical bridging veins, and also due to the fact that they are not well developed, these are thin cerebral veins and are at higher risk. Some non-traumatic causes are coagulopathy due to inherited uh, factor deficiencies leading to coagulopathies, CSF leaks, leading to intracranial hypotension. An example will be in case of lumbar puncture and extraventricular drain. When we try to decrease the volume of the brain all of a sudden, and the volume which we intend to decrease from the brain is much larger, it can lead to the rupture of the bridging vein and eventually an subdural hematoma. Other causes could also be aneurysms within the brain, tumors, or arteriovenous malformations. So, here we covered the basic introduction about subdural hematoma. Later, we went on to discuss about the etiologies which are causing the subdural hematoma. Now we will see what are the symptoms. Usually, very vague symptoms would be loss of consciousness, headache, can be dull headache, severe headache, nausea, dizziness, and pulsating headaches can also be present. Now that we covered about the symptom part, we'll go on to the treatment. The treatment usually depends based on the extent of which the hematoma is present. In case that the hematoma is large, we require urgent management by uh, the treatment also known as craniotomy, where we usually do a burr hole procedure into the brain, and we remove a part of the skull to relieve the intracranial pressure uh, due to the subdural hematoma, and that would allow us to decrease the intracranial pressure to stabilize the neurological problems associated with it. The other thing which we can also do is to clot uh, the blood vessel which is involved, so that the bleeding from where the blood is originating, we basically clot it with the cauterizer, and that would help to stop the bleed as well. So here I have mentioned few steps of the craniotomy. Basically, we usually shave the part of the head which is uh, required based on the non-contrast CT scan of the head. So usual first way of diagnosis will be a non-contrast CT scan of the head. Will shave the part from removing the hair, make the location sterile, and will open the scalp, will drill out the part of the skull, will open the dura mater to access the brain, and will aspirate the hematoma which is present. So that will be the basic idea about the treatment options which we have for subdural hematoma. We also have something known as craniectomy, whereby the only difference between craniotomy and craniectomy is that we, in craniotomy, place the skull bone which we removed earlier back onto the patient's skull, but in case of craniectomy we keep the skull bone out and allow the intracranial pressure to normalize, and we follow up with the patient for another operation so that to place the skull bone which was removed earlier back again to its place. And we also take help of something known as titanium mesh. In that we extend the bone and drill screws by to the place where it needs to be positioned. So we have acute subdural hematoma. Acute subdural hematoma is usually right after the injury. The symptom can be present for 2 to 3 days after the bleed. There can be symptoms like nausea, headache, and coma. Then we have subacute subdural hematoma, in which the bleed is clogged up and there is presence of exudative fluid. The symptoms usually last for 4 to 21 days. Later, this subacute subdural hematoma transforms into the chronic subdural hematoma, whereby there is clotting of blood, there is inflammation, and there is presence of granulation tissue. This occurs over weeks, and the usual symptoms are the patient can be tired, they can be confused, and there might be memory problems. Usually, the memory problems are related to the words which they usually use in their day to day activities, and that might be an indicator that it is a subdural hematoma. There is the Monroe-Kelly doctrine, whereby we have 80% of the brain, 10% of the blood, and 10% of the CSF. So this is the doctrine about the skull content, and in any case there is increase in one of the, suppose if the blood increases, there should be a equivalent decrease in CSF, and so that to maintain the intracranial pressure. In case that is not there, the blood volume increases but the CSF volume remains the same, there will be an increased ICP, and that increased ICP usually present with symptoms as headaches along with neurological along with neurological symptoms. After the diagnosis of the subdural hematoma, we can also utilize the Glasgow Coma Scale to determine the extent of severity that the patient is suffering. So, based on the score of the GCS, we can say if the patient is mild, moderate, or severe. So it usually has the score from 15, which refers that it is fully conscious. 13 to 14 will be the mild impairment. 9 to 12 is moderate impairment. Less than equal to 8 is severe impairment, which refers to coma and often requires intubation. So, subdural hematoma, which is presenting less than equal to 8, we usually intubate the patient so that we prevent hypercapnia. And the hypercapnia, which means increased carbon dioxide in the brain, this increased carbon dioxide in the brain usually leads uh, to vasodilation of the cortical veins and cortical arteries. To prevent this, we usually intubate the patient so that we prevent the vasodilation. Since the vasodilation in the brain with the patient with subdural hematoma will lead to more increase in ICP, and we don't want this, so that to further not to deteriorate the patient's condition. We also have the Cushing triad, which is present, which is basically composed of three factors. There is increased blood pressure, decreased heart rate, and irregular respiration. So it usually is occurring due to the effect on the brainstem, and that will be the reflex due to increased ICP and brain herniation. So that the other thing which we would discuss will be the CAT scan findings. So here, the first CAT scan, we can see there is a bright density on the imaging, and this is usually referring in the left cerebral hemisphere. We can see the bright collection of blood, and it is leading to the compression of the left ventricle, lateral ventricle, and it causes the midline shift towards the right side. So this is a feature of subdural hematoma. Acute blood appears hyperdense, and there is high attenuation on CT due to clotted blood. Um, then we have subacute subdural hematoma, which is present on the second image. It is also the isodense collection, uh, similar to the brain tissue over the right hemisphere. So there is indirect compression of the right lateral ventricle. So this will also cause the compression of the right lateral ventricle and shifting of the midline. Then we have the chronic subdural hematoma. The second image was for the subacute. The third is for chronic, and the first is for acute phase of subdural hematoma. In the chronic phase, what we can see is hypodense, that is, it is dark black, which is compressing the left lateral ventricle, It usually will be greater than 3 weeks, and so it is basically a hematoma resembling the CSF density. So it is like similar to the lateral ventricle color, that is having the presence of CSF. It is similar to the CSF color. So this was the differentiation of the acute, subacute and chronic phases of hematoma. Few other types of hematoma are epidural hematoma, in which we have arterial uh, involvement from the skull fracture. There is a rapid bleeding. It is usually due to uh, the arterial supply of the blood has the fast flow of blood, and that causes rapid bleeding within the skull and the dura. It is usually caused by the middle meningeal artery, and the one which we discussed in this video extensively, subdural hematoma. It is usually due to the vein rupture, due to the broken bridging veins, and it is usually slow because the flow of blood in the veins is slow, and it is usually in between the dura and the arachnoid mater. The treatment which we discussed first were the craniotomy, and the second was the craniectomy. Then the third type which we have is the subarachnoid. It is also referred to as the worst headache of the patient's life. The symptom usually is projectile vomiting, and this is present between the pia and the arachnoid space. So here we discussed most of the content. Finally, before concluding, we'll just go quickly through the uh, brain herniation syndromes. So in the cingulate, that is the subfalcine, which is pushing cingulate gyrus push under the falx cerebri. The CT signs which are usually seen in this case is the midline shift and compression of lateral ventricles. In case of the uncle, that is the transtentorial herniation, there is medial temporal lobe shifting through tentorium. So here on CT, what we can see is dilated contralateral ventricle, compressed midbrain. So it is basically pressing on the brain, and that will also lead to some other neurological findings. The third one which we have is the central, that is the transtentorial, and this is basically also referred to as the diencephalic shift, where the diencephalon or brainstem shift downwards, and this can be seen as direct hemorrhages in pons, the tonsillar cerebellar, where the cerebellar tonsils herniate through the foramen magnum. So this is usually through the foramen magnum present over here. It usually present as obstructed fourth ventricle on CT, leading to hydrocephalus, and the classic finding for hydrocephalus is wet, wacky and wobbly. Then there is upward cerebellar transtentorial herniation, and the CT is like quadrigeminal plate cistern, which we as a medical student mostly don't need to know, but as a resident, I think. Transcalvarial, the brain protrudes through the skull defect, and it is usually post craniotomy. This usually occurs as a complication post craniotomy. So, a few questions which we'll discuss before ending the video. So, a 78-year-old man presenting with worsening confusion over 3 weeks, and they might give you a CT which looks like this. So, which of the following will be the most appropriate step? Will be serial neurological monitoring and chronic, because chronic dural hematoma often expand slowly and are asymptomatic. Small collection may resolve with observation. So that, and the last question will be a 65-year-old man on warfarin falls with drowsiness. CT had reveals an isodense crescentic collection compressing the right lateral ventricle. What technical adjustment best visualizes this pathology? So the answer to it is decreased window width, although I am not given the options, but I am still directly going on to the answers. So narrowing the window width improves contrast resolution for isodense subacute subdural. So that will be it for this video. If you have any doubt, comments, opinion, please let me know down in the comments below. Thank you.